Good evening, everyone. Thanks for sharing your Monday afternoon with the SADA and the Periodontic Society of South Africa. I hope you had a wonderful Monday and that it wasn't a blue Monday. But even if it was, I'm sure tonight's lecture is going to make it worthwhile and change your day for the good. Just a few housekeeping rules. Please, if you have any questions, make use of the Q&A box. Tonight's lecture is for 1 CPD point. The certificates will automatically be uploaded to the SADA platform. You can view your certificate there, but it will also be sent to the HPCSA directly. If you have any trouble accessing the Zoom channel, this will also be streamed live on the YouTube SADA website. Please remember to complete the evaluation at the end of the session. So that completes the housekeeping for this evening. And for me, it's a great privilege to introduce to you a great colleague, a past colleague, and a good friend of mine. I've learned so much from her. I see her as an expert in a field, and I'm so grateful that she was willing to also share her lecture with the rest of you tonight. Without further ado, I would like to now formally introduce Dr. Mia-Michaela Beetge to you. She has a heart and always had a heart for a career in academia. She passed a matric year with 6 distinctions in 2008, and then she completed her BChD degree cum laude. She was the only student out of her class of 55 to obtain a distinction in all her subjects at that time and was second in her class. In 2011, she obtained a distinction for the postgraduate diploma in aesthetic dentistry and passed her MChD degree in Oral Medicine and Periodontics with distinctions in 2015, and in 2019, she was selected for the South African Regional FAIMER Institute Fellowship. Dr. Mia-Michaela Beetge from the Department of Periodontics and Oral Medicine is the latest UP Qualified SAFRI Fellow. Her project involved an educational project that investigated the perceptions of experiences and motivation for selecting and taking part in CPD activities offered in South Africa. She has a special interest in faculty development, and currently Dr. Beetge is in the process of exploring how to bridge the gap between being a clinician and an educator, and hopes to do further research on this topic. She has been part of the Department of Periodontics, the University of Pretoria in South Africa, for more than 10 years, and her passion for her specialty makes her an asset in the department for the school and for our whole profession in South Africa. Dr. Mia-Michaela Beetge, the platform is now yours. Thank you for sharing your knowledge with us tonight.
Thank you, Dr. Potgieter, and it's only my pleasure. Just a moment, sorry. Oof.
For the people joining, I just want to thank you for joining us. And tonight we have our periodontist specialist, Dr. Mia-Michaela Beetge, who's going to help us understand that periodontics can also be applicable to pediatric patients.
Okay, is my PowerPoint visible and is it in presentation mode? Okay, perfect. Thank you. Sorry for the delay. So I want to share with you a lecture topic that Dr. Potgieter asked me to actually do tonight or present today, entitled Periodontal Health in Children. So what I'm going to touch on in this lecture topic is basically periodontal diseases in children. I will go through the steps to actually conduct a thorough history and also clinical examination, how one would go about to reach a definite diagnosis, and also some treatment options I will lay on the table. Then with that, I also want to touch briefly on the periodontal conditions that's associated with pediatric and periodontic, with a pediatric and periodontic focus. And then also I want to highlight some periodontal implications when we deal with patients with dental abnormalities. On the other side of the coin, we will look at some mucogingival procedures, the active Frenum, the gingival overgrowth, and then also other procedures commonly done in the periodontal ward, entitled Your Orthodontic Exposure. We will look at your thin periodontal phenotype, when to do gingival augmentation, when to treat tissue recession, and then briefly touch on missing teeth. So when we look at a diagnosis, especially with periodontal disease in mind in children, it's important to follow the steps entitled history taking, examination, diagnosis, and then we can only do treatment. Now, when we look at the history, we actually are going to discuss a few pointers. There's a nice article that I've referenced that you can take note of. I want to have a specific emphasis on systemic risk factors when we're dealing with this population group. Then I will touch briefly on the basic periodontal exam and also then the role of local factors as well as radiographs when we do periodontal examination in children. Again, we are dealing with a new disease classification, so I will touch on that when I show you a nice case example, and then we can have a look at your periodontal therapy, of which include various phases, and also then when to refer. So this is the article that I referred to. It was published in the Journal of Periodontology in 2000, a rather old article, but again, all the information in this article is still relevant today. It was published in 2001 by Valerie Claire and Aranda Tuknate. If we look at the history-taking process, it's important to take note of the main complaint. Why is the patient in your chair? And also in this regard, have a thorough history of the presenting complaint. History which entails your onset and duration of the complaint. If we also then consider past history, it's important to actually note previous treatment received. Whether the patient had local analgesia and whether there were problems or compliance, and what preventative advice was given during these appointments. If we then consider medical history, I'm going to elaborate a little bit more on this aspect with specific references to the systemic risk factors. And then also social history is of utmost importance because this will actually determine whether the patient can attend a lot of sessions or appointments to come for preventative care. We also have to determine what the motivation of both the child and the parent is, and then take note of the current plaque control regimen. So diagnosis of periodontal conditions should not only involve the child, but also the parent or guardians. And I just want to make a note of when we are dealing with patients that have cardiac lesions or congenital heart defects, the risk for infective endocarditis should be noted. In those instances, antibiotic prophylaxis should be considered, but it's best to work with the patient's cardiologist to actually determine the exact dose and frequency, because ultimately it depends also on the type of procedure that is done. But again, my recommendation always, if one can work with the treating physician, it's the best. Now, if we look at systemic risk factors with gingival manifestations, some risk factors to be considered are hormones, drug, HIV, leukemia, and also then vitamin C deficiency. Now, periodontal disease are plaque-induced infections, and not all patients are necessarily equally prone to develop periodontal disease at the end of the day. Thus, the concept of individual risk has arisen. A risk factor for periodontal disease is a characteristic aspect of behavior or environmental exposure associated with periodontal disease. The association may or may not be casual. Some risk factors are modifiable, whereas others are not. And then we should take note of systemic conditions that should alert the clinician to the likelihood of current periodontal diseases or an increase in future susceptibility. Furthermore, oral signs may be the first presentation of a significant systemic condition that underlies in this specific environment. So this is a very nice article also to refer back to when dealing with systemic diseases that might affect the periodontal attachment apparatus. This was published in the Journal of Clinical Periodontology by the World Workshop in 2017 by Albander, Shushan, and Hughes. The systemic risk factors can be grouped into three main categories. The first being systemic disorders that has a major impact on the loss of periodontal tissues by influencing periodontal inflammation. Under this category, we have genetic disorders, acquired immunodeficiency diseases, and inflammatory diseases. When we deal with the genetic disorders, this could further be subcategorized in diseases associated with immunological diseases or disorders, of which include your Down syndrome, your papillon-Lafayette syndrome, your cyclic neutropenia, your congenital neutropenia, just to name a few. Diseases affecting the oral mucosa and gingival tissues are then the second category in this group. And under this category, we have diseases like your epidermolysis bullosa, your plasminogen deficiency, and your Kindler syndrome. Then we have diseases affecting connective tissues, and those diseases are, for example, your Ehlers-Danlos syndrome, angioedema, and systemic lupus erythematosus. And then last but not least, in this genetic disorder category, we have metabolic as well as endocrine disorders, of which include your diabetes mellitus, obesity, osteoporosis, hyperphosphatasia, to name a few. Under the category acquired immunodeficiency diseases, we can have your acquired neutropenia and HIV. And inflammatory diseases, we are looking at your inflammatory bowel disease and arthritis type conditions, like, for instance, your osteoarthritis and also your rheumatoid arthritis. The second big category are entitled other systemic disorders that influence the pathogenesis of periodontal disease. And these include your emotional stress and depression and smoking. What I just want to highlight under the category of smoking is we have to take cognizant care that if a patient, or in this instance, a child present in your practice with possible periodontal effects or disease, it should be considered that cotinine levels in passive smokers might be as high as some active smokers. Now, I think the jury is still out there on what is this level where the cotinine levels are too high, but it has been shown in the literature that passive smoking are associated with increased cotinine levels. Then the third category is then your systemic disorders that can result in loss of periodontal tissue independent of periodontitis. And under this category, we are dealing with our neoplasms and other disorders that may affect the periodontal tissues, like, for instance, your hyperparathyroidism, your Langerhans histiocytosis, systemic sclerosis, granulomatosis with full angiitis, just to name a few. So that was a mouthful, but at the end of the day, the take-home message is if we have a child with periodontal disease, it should not be taken for granted. We have to evaluate or investigate whether there's not, in actual fact, an underlying systemic condition that we're dealing with as well. With the examination process, we have to consider your general descriptors of periodontal condition, and we also have to evaluate other areas such as the soft tissue, occlusion. I'm going to say a little bit more on the local factors in a moment. Then we use the basic periodontal examination when we're dealing with children. Now, if we look at this basic periodontal examination, this is actually described already in 1992. Well, earlier, the CPI treatment needs was described already in the 1980s. But with the basic periodontal examination, we actually are dealing with a patient, and it was advocated by your American Dental Association and American Academy of Periodontology that periodontal screening and recording in the general practice is recommended for all patients as integral part of oral examination. Now, the BPE, or the basic periodontal examination, is a screening that is done after eruption of the incisor molar teeth. So So we can use this examination when we're dealing with patients from 7 years onwards. I will just have a few words when we're dealing with patients less than 7 years. A WHO probe is used in this instance. I'm going to just have a picture of the probe that is indicated to use with the BPE. Now, if we look at the picture, we can see there's a small ball at the end of the probe, and then we have a big line. Underneath the big dark line, it measures 3.5, and then above the dark line, it measures 5.5. Now, when we utilize this probe, it is indicated to not use more than 25 grams of pressure. Now, this little ball at the end of the probe is actually very nice to detect subgingival calculus. Now, it has to be considered in the age group below 11 years. This basic periodontal examination is difficult to interpret sometimes when we're dealing with the mixed dentition stage. Now, it is recommended to do periodontal screening, and if there is certain areas that one is concerned about, a follow-up appointment can be made for the patient, and if the situation still exists with the follow-up appointment, one can then think in direction of periodontal treatment or then referral. Other probes that can also be used for screening, it is the WHO probe is indicated, but you can also use other probes, and there's some examples of the number A, your Marcus color-coded probe. Number B is your UNC, University of North Carolina, 50mm probe. Then we have our Michigan O probe with Williams markings. We also have number D, Michigan probe, and then your E that refers to your WHO probe. Just going to go back to this examination slide. So if we have a BPE of 1 or 2, I will now go to what these specific codes mean in a moment. We can actually just monitor the indices and also then do a plaque and gingival bleeding index. But the moment we're dealing with a 3 or 4, radiographs are indicated. And also then we have to determine what the plaque and bleeding indexes are, but also what the probing depths, attachment levels are, whether we have bleeding and suppuration present, mobility and furcation. Now, with the mixed dentition stage, like I've mentioned, it is very important to distinguish between a true pocket and a pseudo pocket. Now, this is a very nice diagram from the Ruttercheck handbook, or textbook, where we see the dentogingival complex that consists out of A, B, and C. A represents our histological sulcus, B, the junctional epithelium, and C, your dentogingival fibers. Whereas the biological width, or newer terminology, the supracrestral attached tissues, only consist of the junctional epithelium and the dentogingival fibers. Now, the moment we have loss of number C, now number C starts at the CEJ and go downwards toward the alveolar bone in a normal situation. When we get destruction of these fibers, that's when we will have a true pocket formation. If the entire dentogingival complex has not shifted downwards, if that is the case, when we're dealing with recession and not periodontitis. So periodontitis, in other words, is when we have a pocket of 4 millimeters and more together with attachment loss. Now, when we don't have attachment loss, we don't have destruction of these dentogingival fibers that's marked by C, but we have enlargement of number A and B. We can also have a reading of 4 millimeters and more, but this is then your pseudo pocket or your false pocket. Now, when we have a mixed dentition stage, this should be taken into account that you're not dealing with a pseudo pocket, but in actual fact with a true pocket. And like I said, when in doubt, rather make a follow-up appointment for the patient. And when the situation still remain the same, then I will intervene or take it further. When we look at the codes, 0 represents a healthy periodontium. 1 is there's bleeding present, but again, bleeding has to be interpreted with care. It is indicated that we don't use a force more than 25 grams, but also, again, your thickness of your probe, your angulation of your probe, the consistency of the tissues all can play a role with regards to bleeding. Calculus or plaque retention is when we have, when we can actually give a code 2. And then when we are dealing with pockets 4 and 5, it is given a code 3. And then a code 4 is when we're dealing with a pocket 6 millimeters and more. That is now referring to a true pocket. Now, we're only restricted to use codes 0 to 2 when we're dealing with the 7 to 11 years population group, but like I've mentioned, when you are adult, tooth eruption do take place on a continual basis. So if you get the patient back and it still remains a true pocket, then I would definitely intervene. Some local risk factors that should also be then considered is then obviously your plaque retentive factors, of which include your caries, supra and subgingival calculus, subgingival restorations, defective restorative margins and overhangs. Also, your fixed and removable orthodontic appliances might play a role in accumulating excessive plaque, and then malocclusions. Then we can also have mouth breathing and incompetent lip seal. Now, mouth breathing, if we're dealing with these cases, we frequently see gingivitis on the palatal surfaces of the maxillary anterior teeth, whereas your incompetent lip seal might present with gingivitis on the labial as well as the palatal surfaces. Your xerostomia that can be found in your patients that underwent radiotherapy or even chemotherapy, your typical cancer patients, and then also your developmental dental features like your enamel projections, enamel pulls, proximal palatal gingival grooves may be more plaque retentive and consequently may lead to more periodontal destruction in this area if other factors are also present. Now, with regards to radiographs, I think we are in a situation where we can take a radiograph very easily, but it must always be kept in mind that the radiation dosages of radiographs are cumulative over a patient's lifetime. So when we do take a decision to take a radiograph, it should be conservative and justifiable. It is recommended to use bite wings in children, so then one can assess both the alveolar bone and caries. And then also a panoramic radiograph might also be indicated to assess the presence or absence of permanent teeth and also then for orthodontic purposes. Now, under normal circumstances, we have the crest of the alveolar bone that's approximately 1 to 2 millimeters below the CEJ located. Whenever we have a situation where this bone is more than 2 millimeters below the CEJ, then one have to investigate together with your clinical examination. Just remember, your radiographs only assess hard tissue. You cannot assess soft tissue on radiograph. So radiographs are considered adjunct. You can do a periodontal examination without radiographs and reach a definite diagnosis. But this can be used as an adjunct, but like I've mentioned, it must be conservative and justifiable when taking a radiograph. Okay, so in a nutshell, we have now touched on the history and examination. If we then look at the diagnosis, it's important for communication purposes to have a classification. Again, there's a lot of classifications that's available in the literature. The AAP, the recent AAP 2017/2018, I will briefly touch on. We also have the Van der Velden classification. Diagnosis is also important at the end of the day because you can't employ any treatment if you don't have a diagnosis. It is important to differentiate between gingivitis and periodontitis. We've discussed the true pocket versus the pseudopocket. A pseudopocket that is most frequently associated with gingivitis and a true pocket with periodontitis if there is attachment loss also present. And then we can also deal with a mucogingival problem, like for instance your recession. So I'm going to then go on to just a brief description of the classification, or you can read the article yourself. It was published by the World Workshop, again, various authors, Papineau, the leading author, that actually compiled in the classification, where it's basically when we deal with periodontal diseases and conditions categorized in your periodontal health, gingival diseases and conditions, periodontitis, and then other conditions affecting the periodontium. And then we can also see then if you have made your diagnosis, whether you are dealing with a case that has gingivitis or periodontitis. If it is in actual fact periodontitis, we will go on and grade or diagnose the disease severity and also then the complexity of management by means of staging and grading the individual case. So again, if we look now at this specific case that I want to show an example of, I think it's very important to, first of all, if we can summarize what have been said so far, to do a screening as routine dental care. If you are in doubt, schedule a follow-up appointment. If the patient comes back the second time and there's still reasons for concern, periodontal therapy should be employed or prompt referrals should take place. Now, this was a case that was seen in our ward. It's one of the registrar's patients, and then this patient was 13 years old when she initially presented. You can see a lot of gingival inflammation, a lot of plaque deposits on the teeth. The patient presented with the main complaint that she cannot eat, and she says her mouth is painful, according to the words of her parents. History of the main complaint, she said she had constant discomfort already experienced at age 9. The pain is intermittent. There is bleeding that is noticed, mobile teeth that are noticed, and then a private practice dentist referred the patient, initially thought the patient had necrotizing ulcerative gingivitis, and then a prescription was given. Now, I'm not going to elaborate on this treatment that has been done, but what I can say is then from a medical point of view, the patient was referred to a pediatrician. The patient did not know of any underlying systemic conditions or genetic factors present in the family. The report from the pediatrician came back with nothing abnormally that was found with the patient, but it must be said that this patient was small in stature, so it won't be a surprise if there is in actual fact something to be concerned of from a systemic point of view. Dental history, she's not a regular dental attender before she actually came to the hospital. And like I said, from a social point of view, you can see the oral care is not what it should be. You can also see that the patient has probing depths together with attachment loss. If you look at the clinical photo, the recession defects, the biggest probing depth being 6. And then the panoramic radiograph showing the bone picture in this instance. I did not put all the periapical radiographs. We did do a full mouth periapical radiographs in this case as well, a full tooth by tooth analysis. But I just want to highlight and show you that there are in actual fact cases out there that should not be missed. This patient already presented with the main complaint when she was 9 years old. When she presented at the hospital, she was already 13, and a lot of the teeth could have been saved with regards to if we did pick up it earlier. Now, when we look at the classification, generalized periodontitis, referring to more than 30% of the sites that's involved periodontitis, we have pockets of 4 and more, we have attachment loss. Stage 3 is when we are dealing with a situation where we have attachment loss of 5 millimeters or more. And then grade C is when we divide the percentage of the bone loss. In this case, we can see 40% on this specific periapical radiograph divided by the patient's age, that's 13, and that gives us a value more than 1, so that will put her in a grade C category at the end of the day. Again, I'm not going to give a lot of input with regards to the classification. This is the newest classification that we use, that you utilize in the ward and also teach the undergraduate students. We can have a whole discussion on the classification with the pros and the cons, but I don't think it's really the place or time today. So if we then move on to periodontal conditions with pediatric as well as periodontic focus, I think dental trauma is also a very important topic, also a presentation on its own, but I just want to make a few or highlight a few points. And if we deal with the periodontium, when we have trauma, we either have ischemia, crushing, or loss of the periodontium. Also a very nice article that you can refer to is the Management of Periodontal Health in Children, Pediatric Dentistry and Periodontal Interface by Drummond. It was also published in the Journal of Periodontology 2000. So outcomes of healing, depending on the trauma, can be then repair. I have nice videos that I can show you with regards to what will happen when we have a large defect versus a small defect repair. So infection-related root resorption can also occur. Ankylosis-related resorption can also have cervical invasive root resorption, and then obviously your loss of alveolar bone support. This is then a video just explaining what will happen if we have a small defect and lean towards the repair aspect of the periodontium.
But what happens when the periodontal attachment to the teeth is compromised, for example, by mechanical trauma or defect? Macrophages migrate from the margin of the intact periodontal ligament into the damaged area and remove necrotic fragments. They can transform into multinucleated odontoclasts capable of removing superficial cementum. When there is no more necrotic tissue left, macrophages can switch to regeneration by releasing signaling molecules for angiogenesis and recruitment of regenerative stem cells. These messenger substances trigger differentiation of new cementoblasts, which entirely repair the cementum layer in small defects. The process of regeneration of the periodontal ligament is called surface repair. If the damaged area along the root surface is larger than a few millimeters, the periodontal ligament cells may be unable to migrate the long way from the adjacent intact periodontal ligament spaces.
Okay, so in your large defects, we would...
But what happens when the periodontal attachment to the teeth is compromised, for example, by mechanical trauma or defect? Macrophages migrate from the margin of the intact periodontal ligament into the damaged area and remove necrotic fragments. Onto ligament spaces. Instead, osteoblasts from the adjacent alveolar bone, which is only 200 micrometers away from the root, are activated. Signaling molecules, including differentiation factors like bone morphogenetic proteins, enhance bone formation. The newly formed bone thus approaches the tooth root. Since the cementum layer as a borderline is lacking, normal bone remodeling extends without barrier into the root dentin. By this time, bone replaces the root dentin. This process is called replacement resorption and results clinically in ankylosis.
My apologies for playing the first video twice. So basically what it boils down to is when we have a small defect and there are periodontal ligament nearby, the periodontal ligaments supply the stem cells that can actually then regenerate and form cementoblasts. In contrast to a large defect where we don't have the periodontal ligament. So in these cases, we won't have the cementum reform, and that is where we have then the replacement resorption, and then ankylosis can occur. Now, immature teeth with open apices, we can expect that bone regeneration is likely. But when we are dealing with mature teeth, transient or permanent loss of bone may occur. And obviously the healing will depend on the type of injury and also then the stem cell capability. And that is also then touching on the periodontal ligament again. So the periodontal implications of dental anomalies. Now, this is a patient that presented again in our ward. You can see the typical ghost teeth or no roots. You can. It was a 13-year-old female patient that was then referred from private. But when she was referred, I actually asked for the span. She presented with me with, I asked for the 2 previous spans. She presented actually with a removable partial denture where the front teeth were already taken out. Now, again, it's a very difficult case to actually treat. At the end of the day, we have the diagnosis of dentinogenesis imperfecta, and that's why we don't have the roots that were formed in this specific case. Amelogenesis, on the other hand, are much more common than dentogenesis imperfecta. Now, the most important consequence for all these individuals is difficulty in carrying out effective oral hygiene because of the sensitivity associated with the defects. In addition, teeth may be prone to fracture, often close to the gingival margins, and this can also compromise restorative care, especially when the margins are then placed subgingivally. Oral hygiene can be facilitated by use of warm water, desensitizing toothpaste, soft brushes, and mouthwashes. And a good interim restoration is needed to improve the longevity of the teeth and reduce the need for repeat restorations. Now, in this case, she's currently one of the patients where we just emphasize good oral hygiene and try to maintain the teeth that is still present in the oral cavity for as long as possible. I will touch on implant placement right at the end, but ultimately we want to postpone implant therapy for as long as possible because the patient is still a growing patient. This is again another example where we are dealing with dental anomalies, and we can see we have tooth roots in this case, but we don't have any enamel. So this is a typical example of amelogenesis imperfecta. Again, like I said, much more common than the dentogenesis imperfecta. But in this case, also very difficult for the patient to keep clean because it's actually sensitive for them to keep clean. And that is why we can actually then get them into a maintenance program, help them ultimately, and then also that is where we can also have our combination with the or collaboration with the restorative dentist that actually can fabricate crowns, can help this patient to actually keep the teeth for as long as possible. Then we move on to the mucogingival procedures. I think that's what you're all waiting for at this stage, but I don't think we must underestimate the importance of diagnosing periodontal disease in children. Now, Phrenectomy is the one mucogingival procedure that we frequently see in our ward, but also the one that actually have a lot of questions. So my thinking of addressing this topic is to actually then answer some of the questions that are out there. Hopefully there will be still more questions after the lecture, and that we can actually go then from there. So if we look at the etiology, now etiology is then basically, if we look at the frenum, it is a membranous fold that contains muscle, connective tissue fibers, and it actually attaches then the lip to our tongue to our alveolar mucosa, gingiva, and underlying periosteum. And then also it provides stability for the upper and lower lip and tongue. Now, if we look at the aberrant frenum, an aberrant frenum can be treated by means of a Phrenectomy or Phrenotomy. Now, the difference between a Phrenectomy and a Phrenotomy is the Phrenectomy is the complete removal of the frenum, which includes the frenum attachment and also the underlying bone, versus the Phrenotomy, that's incision and relocation of the frenal attachment in a more apical position. This is also done when you want to increase the zone of the attached gingiva between the gingival margin and then the frenum. Now, diagnosis, if we have to diagnose then a frenum, is we actually have to pull the underlip and then in a left and right motion, actually pull the frenum forward. Now, when we apply this tension to the lip, we actually can see then blanching that is produced due to ischemia in the region. And when we have this blanching, it indicates a pathogenic frenum. Now, sometimes you can also have a flattened papilla with the frenum that's closely attached to the gingival margin, causes gingival recession, when it's unusually wide, when there's no zone of attached gingiva along the midline, and also then when we have an interdental papilla that shifts when we have the frenum extended. Now, if we look at treatment options, now aberrant frenum with inadequate attached gingiva, as I mentioned, and a shallow vestibule. Now, this comes down to the patient can't clean properly. The patient can't get a toothbrush into the vestibule and clean. So that is definitely an indication to remove the inactive frenum. And that goes hand in hand with the proper plaque control measures. Now, when we have a frenal attachment that is a cause of a midline diastema, the rule of thumb is that we must investigate by taking a radiograph if we're not dealing with either a cyst or a mesiodent. When that is excluded, then we have to wait secondly for the canines to erupt before any surgery is attempted. And then also Ankylglossia is also an indication for frenum removal. Now, this is a typical example of Ankylglossia or tongue tie. It's a congenital anomaly where we are dealing, or when we can see a short, tight lingual frenum, and then as consequent, limited mobility of the tongue. Now, clinical features associated with Ankylglossia include swallowing dysfunction, difficulty in speech articulation, difficulty in breastfeeding, and also when the tongue is protruded or sticked out, then the patient has this typical heart-shaped tongue. Now, there's an example of a nice thick lingual frenum. After the surgery, you can see that the tongue movement was increased and the patient could, in actual fact, then stick out their tongue. Then I want to stand still addressing the correct timing of the treatment. Now, my question here is, if you look at this picture, it doesn't show you all, but I think it shows the necessary information you need to answer this question. And my question here is, was this case treated during the correct time frame? Now, obviously, there's no interaction, so I will give you the answer, and the answer is no. There is a midline diastema present, yes. But at the end of the day, this patient is still growing. The canines have not erupted. And it's that typical ugly duckling stage that we can see. So it is not the correct timing to treat these patients before the canines have erupted. The video that I showed you where we actually test the mobility of the frenum, that was also not the correct timing of performing the Phrenectomy. We have to wait until the canines erupt, because then we can actually appreciate the true extent of the frenum and whether or not it is in actual fact pathogenic. Okay, so take home message. In infants, when a baby is born with a active frenum, a lactation consultant or specialist should be addressed, or advice should be sought first. If one does not come right, then oral surgeon can be the last option, according to the literature. One has to be preventative or conservative in this instance. Like I said, it is actually done most often without valid or the valid steps or procedures that have been followed. So after lactation consultant have been addressed and still the infant cannot come right with breastfeeding, then my suggestion is to refer these patients to an oral surgeon. Toddlers between 2 and 4 years specifically, no referral is necessary. There's no problem with these patient age group, because when a patient is between 2 and 4 years, obviously they can eat. We have to wait for the growth. And many times we can actually see that what appears to be an active frenum initially actually goes away by itself as the child grows. Children then wait until canines erupt, or wait until orthodontic treatment is completed. Again, there's various schools of thought. Some orthodontists will refer for a frenectomy because they argue that to close the midline diastema, they can't do it when the frenum is active. Conservative treatment can be looked at, but at the end of the day, one should consider possible scar formation that can form after frenectomy procedures are done, and one should actually question whether that might have an influence on either our incisor eruption, incisors to erupt, or even then the orthodontic movement after the frenectomy. Okay, so then the second aspect or topic that I want to look at is then gingival overgrowth. Now, gingival overgrowth, a nice article that was published in 2017 in the British Dental Journal by Mon. There is a part 1 and 2 series. I've only referenced the part 1 series where they actually looked at the etiology and clinical diagnosis. Now, when we look at gingival overgrowth, it can be divided into overgrowth due to local factors or then systemic factors. Now, not all of these factors are applicable to children, like for instance, your pregnancy, hopefully. But if we look then at local factors, we have our acute versus chronic. Acute, where we're dealing with abscesses, pericoronitis, fibrous epilus, pyogenic granuloma, or more correct, your lobular capillary hemangioma, plasma cell gingivitis, and then iatrogenic cases. Then we can also have false enlargement, that is dental, your altered passive eruption, or also odontogenic cyst, underlying hard tissue conditions like your Patch's disease, fibrous dysplasia, and then your new plastic conditions or lesions that should be considered. That is then grouped into your benign and malignant lesions. Hormonal, when dealing with the pediatric population, puberty, menstruation, oral contraceptives should be on the list. Drug influence, gingival overgrowth, where we specifically have our calcium channel blockers, anticonvulsants, and phenytoin, and also cyclosporin. Leukemia. Again, I'm going to come back to this most important cause of gingival overgrowth that should not be overlooked. Also lymphoma, malnutrition, granuloma disorders, and also hereditary conditions might also be a reason for gingival overgrowth. So as you can see, there's a lot of reasons why we can have gingival overgrowth, and it's not easy to come to a definite diagnosis always. Now, this is also just some mechanisms of actions I want to briefly touch on. Like we've mentioned, your drug-induced hormonal, and then your neoplasm is where I want to actually end at. Now, if we look at our gingival overgrowth situation, whether it is due to a drug, whether it is due to hormones, you will always have an inflammatory component. As we don't have physiological tissues that will then be more plaque retentive. Now, this can aggravate the whole gingival overgrowth situation because we have the inflammatory cells that secrete inflammatory cytokines. This can lead to tissue destruction, and in the attempt of healing, we can have increased angiogenesis, And that is the typical red, swollen appearance of the gingiva. And also then your older lesions might be more fibrotic, where we have an increase in the fibrosis. When we look at the drug-induced, we've mentioned the calcium channel blockers, that's phenytoin or anticonvulsants, and also your cyclosporin. Now, the mechanism in this specific category is ultimately calcium metabolism is affected and dysregulated. Now, calcium is responsible for collagen degradation as well as remodeling, and a decrease in degradation and remodeling occur, and that gives rise to gingival overgrowth. And when it's severe, it can also lead to your tooth displacement, speech problems, aesthetic problems, and also then breathing problems. Hormone-induced, like I said, puberty and use of oral contraceptives are mainly seen in children. It's not the hormones per se that contribute to the gingival overgrowth, but more altered tissue metabolism. And if we look at the altered tissue metabolism, we can have the tissues that are more sensitive to local irritants. And in this instance, if we look at the role of estrogen and progesterone on the blood vessels, we can see that just a moment, sorry. The estrogen receptors are found on the keratinocytes of fibroblasts, and this increase in estrogen can cause an increase in cell proliferation and differentiation, versus your progesterone is where we can have have increased vascular permeability, and this is the reason why we have then this increased response or sensitivity to local irritants. Then if we look at the neoplasm-induced, it's leukemia. Now, leukemia obviously is the infiltration of gingival tissues with neoplastic cells, and we have this typical appearance of a blue edematous soft tender gingiva. Very, very, very important that does not respond to plaque control measures. If you have a patient, not your normal typical hormonal case, not history of drugs, the inflammatory component, not a lot of plaque, you did do a thorough debridement and still it looks the same, please rather take a biopsy, send for a full blood count or refer, because this might be a possible case of leukemia. I can't emphasize this enough, and that is why I want to discuss this specific mucogingival procedure, because at the end of the day, if we diagnose a leukemia early, the treatment outcome might be much better compared to a late diagnosis. Now, how do we reach a definite diagnosis? Again, main complaint is very important. At the end of the day, you have to listen to your patient. The main complaint is also accompanied by the duration of onset. Is there any associated pain, bleeding, tooth mobility, or any other symptoms? And that should be taken note of. Then we have our dental history. What should be taken note of in this specific category is previous treatment, your history of hygiene appointments, and your patient's usual hygiene regime. With our social history, one can identify risk factors here. Family history also may aid in the diagnosis of a condition with a genetic element, like for instance, your hereditary gingival fibromatosis and also neurofibromatosis. Now, medical history will give information about drugs being taken, the temporal relationship between beginning a course of medication and also the onset of overgrowth may provide valuable diagnostic information regarding etiology with overgrowth presenting as early as 1 month after commencement of medication. One can also take into consideration previous drug history, because that might also be important in the diagnosis if a patient had recently stopped taking drugs that can be related to gingival overgrowth. And then obviously the clinical examination. Now, when do we treat? When do we refer? Now, always address the cause first. So you have to make a diagnosis. If you're not able to make a diagnosis, please refer. Improve the oral hygiene and reassess after 6 months. You can also reassess after 3 months. Primarily as a drug side effect, request substitution of the current drug by communication with the patient's physician. Some substitutions for phenytoin include your carbamazepine or valproic acid. For cyclosporin and tacrolimus, and calcium channel blockers is your beta blockers, ACC inhibitors, and diuretics. Now, we won't see your antihypertensive medication in children, except if they are patients that has renal problems, for example, or other heart problems. Then a gingivectomy or gingivoplasty procedures are then employed to correct physiological contours, but that would only be the last step after the cause have been addressed, after supragingival and subgingival debridement has been done. Now, these are some cases. This is then a before and an after photo. You can see some gingival overgrowth in the before photo, and just after one debridement appointment, already the improvement without any surgical intervention. In this patient, we could see, this is a patient that was referred. She was on cyclosporin A. We did the gingivectomy, but unfortunately they could not afford being placed on tacrolimus, so she has been in the practice more than once already. Then orthodontics. Again, we frequently see gingival overgrowth when patients are on braces. Now, a lot of orthodontists refer these cases to have a gingivectomy done, but it should be done with care. In this instance, we did do a gingivectomy using the laser, very conservative, because at the end of the day, this gingival overgrowth will improve if the braces are removed. Sometimes we sit with a situation where the tissues are very thick and fibrotic, and orthodontists may argue that they do struggle to move the teeth. Then we can intervene. But like I said, your approach should be conservative, and this is really the exception and not the rule. We prefer to do any gingival overgrowth cases after the orthodontic treatment has been completed. The patient will undergo at least 3 debridement appointments. And more often than not, no surgical intervention is necessary in these cases. So what's the take-home message? Any rapid change in the oral cavity should be handled with caution, as it can be indicative of an underlying systemic condition or ill health. Failure to respond to treatment, like for instance your debridement, onward referral and further investigation is warranted in these cases. So other mucogingival procedures undertaken in children include our orthodontic exposures. Here I will just show some pictures. I'm more or less finished with the lecture. So if there are any questions, please type your questions. I will be glad to answer or try to answer it. Here it was a patient that's worked up from our orthodontic colleagues. We removed the primary central incisor, exposed the permanent central incisor, attached a chain, for it then to be drawn out into correct form before then orthodontic alignment will take place. Again, here we're dealing with the impacted canine. Canine was removed. We have absent lateral in this instance, and then also the chain that was attached to then bring the canine down. Orthodontic exposures don't need to be so gruesome and so big. In this specific case, you can see a simple incision was made just to help the central incisors erupt, as the overlying gingival tissues was quite fibrous, and the central incisors could just not erupt. Again, in this instance, one have to take into consideration early removal of primary teeth might also play a big role for your permanent teeth not to erupt, as they aid as a guideline. So in these instances, we can have situations where the overlying gingival tissues become rather thick and sometimes need help to get the permanent successors into place. Then gingival augmentation. Again, there's also a lot of information in the literature whether we should augment or not. I'm referring a lot to the 2017 World Workshop. This article entitled Mucogingival Conditions in the Natural Dentition by Cortellini and Besada. And what the take-home message in this article is, basically case B, they categorize it in 4 cases. Now, case B and case D will indicate additional augmentation of soft tissue. In case B, we have a thin gingival biotype, and an application of gingival surgery in high-risk sites should be considered, especially in cases where we are thinking of doing orthodontics, restorative dentistry with intrasulcular margins, or implant therapy. In case D is when we have aesthetics and or dentine hypersensitivity together with cervical caries. And in these cases, for mucogingival surgery for root coverage purposes, if we again have thin phenotypes, it is advocated to do gingival augmentation. When we do orthodontics, again, restorative dentistry with intrasulcular margins and implant therapy. Now, this is also one of my cases. She was a little bit older, but again, a very aggressive early onset periodontal case that had orthodontic treatment while she presented when she was currently in the orthodontic treatment. On the cone beam CT scan, it showed that there was no alveolar bone whatsoever. So the decision was made to actually augment the soft tissues in this case. She did have recession, you can see that, but that was not the aim of doing the free epithelialized grafts that were harvested from the masticatory mucosa of the palate. It was actually to augment this area so that the patient won't struggle with future recessions in the other teeth. So you can see in this instance the nice healing that took place, really nice thicker tissues creating a vestibule for the patient to keep clean. And we actually did do a slight coronally advanced flap at a later stage to correct the recession defect even more. But obviously recession, again, a whole set or a whole webinar on its own where we discuss the different types of recession and when we can actually achieve 100%. In this instance, we could not achieve 100% because of the soft tissue loss interproximally. Then last but not least is dental implants. Now, dental implants at the end of the day should only be considered when craniofacial growth is completed. That is in the literature, girls between 18 and 19, boys 20 to 21 years. But again, my opinion is it is a very individualized assessment. Some literature refer to doing a safe tracing and after a year do another, and only when growth did not occur within that year, you can assume that craniofacial growth is completed. Again, if you go to the literature, some state that craniofacial growth will never complete. So in children, one has to take cautions. There are many implants that are advocated, but again, I think a thorough workup, a thorough evaluation of the pros and cons should be done first before implants are placed, especially in the anterior region. So in conclusion, periodontal disease in a child, you should rule out any systemic disease. Now, the best approach to manage periodontal disease is prevention, followed by early detection and treatment. And then, very important, to first diagnose, then treat or refer. So that is all from my side. Thank you for your attention, and I will answer any questions now.
Wow, what a lecture, Michaela. Thank you so much. I think it is information overload, and you took such a big topic and you compressed it so nice and functional so that we can apply it to our practice. So you actually have a lot of questions, which is a good thing. So I'm going to jump right into them. The first thing is, would you recommend standard periodontal probing for all pediatric patients during perio screening?
Okay, so standard periodontal probing, no. Screening using your basic periodontal examination, screening a tooth here and there, yes. if you do your basic periodontal examination and you come across some deeper sites that you are concerned about, this basic periodontal examination then warrants a further full periodontal examination. So I would not do a full periodontal examination on all children, being the probing, but definitely your basic periodontal examination.
Okay, thank you. Then there's a question regarding the classification. There's questions regarding whether the old way of referring to early onset and juvenile periodontitis, where it now kind of fits into the classification, if it's correct to then also classify it as localized aggressive periodontitis.
Okay, I have mentioned about the classification. Personally, I think there's a lot of shortcomings with the presentation. And again, if you read the classification, it's not only one article, it's a bunch of articles. And the main reason why they disregard aggressive is because ultimately the treatment is the same. But that's now set on the one hand. The other hand, they don't see the patients we see in Africa, in South Africa. So for me, I treat a patient with aggressive early onset type of periodontitis different from a patient with chronic periodontitis. And again, if you want to argue the whole antibiotic resistance issue, if you go onto the WHO website, you can see we don't have an antibiotic that has been produced for the past 30, 40 years. So resistance is a problem. In the European countries, they actually use for all their periodontitis cases antibiotics. I don't use it in all my cases. I reserve antibiotics for my aggressive early onset cases. So in my opinion, there is not made provision, and it's a shortcoming for me in the classification. But we have to put information out there that they consider it, because there will be another world workshop soon. And then if we can show the results that we actually need to incorporate it because the treatment is different, then maybe they will consider adding it again.
Okay, awesome. Thank you. You already started to touch on the next question, which was if you need to also include antibiotic systemic therapy, what your treatment regime would include, whether it will be amoxicillin and metronidazole or a combination of the two.
Okay, so basically with our chemotherapeutics, again, it should not be a substitution. So I want to highlight that. That's why I didn't even incorporate it. First of all, the focus should be the diagnosis and treatment. The cause of periodontitis, if we specifically look at periodontitis now, is the baffle. We have to remove the baffle. If you do want to treat a patient with periodontitis, if you feel you are under control, I would employ antibiotic therapy, like I've mentioned now previously. With your normal gingivitis cases, I'm not referring to your necrotizing ulcerative gingivitis cases. Gingivitis cleaning would be sufficient. Necrotizing ulcerative gingivitis, again, cleaning with adjunctive antibiotics. It is mainly anaerobes that we're dealing with. So metronidazole is the antibiotic of choice. But then if you think a little bit more out of the box, the patient can't keep clean. So obviously we will have plaque accumulation. So the patient might benefit from a broad spectrum amoxicillin, for instance, as well. So I like to give it as combination for that reason, but the literature shows that metronidazole is sufficient. Again, coming back to periodontitis, I would use it as an adjunct, but do the debridement first. Never treat a patient with antibiotics if you did not do the debridement. If you look at the baffle, it is only going to contribute and worsen the whole antibiotic resistance issue. The baffle is protected, so nothing you give will actually penetrate, not even chlorhexidine malference. So it can actually prevent the biofilm to get bigger chlorhexidine if you look at the mechanism of action, but it will not eradicate the organisms at all.
Okay, thank you. So the next question is if you have any literature or knowledge on the incidence of periodontitis in children, how common it actually is.
It's not that common. It's actually, but having said that, we don't know how many cases are out there that don't get to our central referring sites. So I think it is out there. We did have one or two cases that I know of in my 10 years at the university, but I think it is underdiagnosed, my honest opinion, because if you look at the patients 18, 17, 18, the question is, when did it start? So the specific literature on incidence, I won't think it is correct. I think it will start with us, with every dentist to actually try to diagnose, and then maybe the incidence will increase if we are made aware to actually do the basic periodontal examination.
Okay, thank you. And an interesting question. Did you pick up any increase or change in periodontal health after the COVID-19, either infection, vaccine, or booster?
Not yet in studies that I specifically looked at in this age group, but again, one should actually consider whether it should have a role. But it's also going to be, if you look at your relationship with diabetes mellitus, with your other cardiovascular diseases, it might have an influence. But to make exact causal relations to each other, it's going to be difficult, because the question is going to be what other confounding factors could actually also play a role. And then having said that, one should actually also ask, wearing a mask, but now again, that's more in the adult population. You smell your own breath. So I think patients seek dental treatment more frequently if they have the finances. Then you have to now consider the financial aspect again. So I don't really know. Sorry.
No, it's
interesting
good.
Question that maybe should be investigated further.
Okay, awesome. Thanks. Then there's also one of the participants who wanted your comment on psoriatic arthritis, which is a form of allergic arthritis, and its presentation in children. Do you have any comment regarding that?
If you look at the systemic conditions, obviously it will fit under the endocrine disorders, and it can also, like your rheumatoid arthritis, like your osteoarthritis, I think it will fit in the same category and also be then a possible reason why we might have periodontal destruction, definitely.
Okay, so moving away from the perio, moving to the surgical procedures, there was a question on whether the specific case will actually determine your choice between laser and scalpel for frenectomy.
Okay, yeah. So again, I think it depends on what laser you have. There's a lot of lasers on the market. I like the scalpel personally for your bigger, broader type of frenums. We only have diode and ER-YAG lasers in the ward, so I don't have the privilege of working with, for instance, your biolaser. My experience with doing frenectomies with a laser is it tends to reattach sometimes if it is not a small frenum. So that is my experience with regards to the healing. If you think about the healing and your different inflammatory phases, we have our hemostasis that is now controlled by the laser, your inflammatory phase, and then obviously your proliferative and your maturation phase. Now that inflammatory phase is basically where we have our neutrophils, macrophages cleaning the area of bacteria and necrotic debris. When we use the laser, that area is much larger compared to your scalpel. So there is in the literature signs that when we use the frenectomy for bigger areas, it might cause more scar tissue compared to a scalpel that will heal by first intention healing.
Okay, thank you. So then we also have an interesting question that there are opinions that you have to do the frenectomy as soon as the 1-1 and the 2-1 erupt, and that will allow natural diastema closure so that you need less orthodontic treatment later in life. What is your opinion regarding that?
I don't agree with that. I'm of one of the old school that would rather wait for the canines to erupt. And like I said, with regards to if there's not space, there's not space. I can't see how removal of the frenum might have bodily movement as such great extent that it can actually cause it. And then again, like I've mentioned, one has to question the scar tissue that forms when we do a frenectomy. So I'm not entirely convinced that that is the way I would do it. I would rather be one of those who wait for the canines to erupt, wait until orthodontic treatment has been completed before I do the frenectomy.
Okay, another frenectomy question. If you have a 6-month-old baby with an obvious active lingual frenum or short attached lingual frenum, and the baby is not struggling with breastfeeding, but you have an obvious frenum, would you refrain from treatment or would you treat anyway?
Lingual frenum versus labial frenum, I think it can be placed into separate categories. So lingual frenum or Ankylglossia might have speech problems later as consequence. So if a lingual frenum is diagnosed, I won't hesitate in treating it as soon as possible. But I don't, labial frenum, one should be more conservative. But lingual frenum, Ankylglossia, one can go about and treat that, yes.
Okay, thank you. And then regarding exposure of unerupted teeth with those fibrotic tissue, how long is a good indication to wait for that tooth to naturally come out before you intervene surgically?
Again, it depends on the eruption pattern of the child. So I think that should be taken in consideration. And also, it depends. I would say if you can see the entire root formation or 2/3 of the root formation and the tooth is just not erupting, you can maybe see the patient and schedule a 6-month follow-up, and if nothing has occurred, then I would intervene. But I think that the important aspect to highlight here is to actually consider the root formation that has taken place on a radiograph.
Thank you. I think that's great advice, great practical advice we can use in our practice. I just want to tell you, Michaela, there were so many compliments in the chat box and the question box. You even got a job offer overseas. So I'll share the email address with you afterwards. You were invited to also speak in the USA. So we'll share with you the comments, but we really appreciate you taking such a big topic and compressing it for our audience. And I think from all that I could see in the chat box and the questions and answers, people really enjoyed your very informative lecture. Thank you so much.
Shame. Thank you, everyone. And thank you, Dr. Potgieter. I appreciate the opportunity.
Okay, then I wish all of you a great evening. I just want to remind you of the upcoming events. The first one is 1 March with Sada and Henry Shah in Dental Warehouse. It's a tooth whitening and aesthetic dentistry with the legendary Dr. Mark Bowles. So don't forget to register for that. And the Periodontic Society has the bruxism branch, also a very interesting topic, questions we get a lot from the public. Children and bruxism, we have a bruxism branch, which is a live event and going to be so much fun. So we have limited space due to COVID regulations, so please go and register as soon as possible. And we look forward to seeing you there. Thanks for spending your Blue Monday evening with us, and we hope that Michaela changed it into a great evening. Enjoy your evening, everyone.
Thank you, ladies.